fluffy and maybe.
That's us by definition.
Yeah, we're both fluffy. Fluffy together. So again, I'm John Marshall, the chair of emergency medicine at Maimonides. To my right, Ron Simons, our director of trauma, emergency surgery, and surgical critical care, and probably a couple other things.
Yeah.
So we're talking about playing nice in the sandbox, and just to start with a set of definitions, this is obviously the sandbox, right? Not as many ambulances are out there usually, so you can actually see it. Our adult pediatric trauma center, or more aptly, this room, room 51, recess 1, which is our primary trauma bay, where most of this happens on a regular basis. And what we want to talk about is how we've been working together over the last couple of years to make all of this work really, I think incredibly well. And I just want to give you a little bit of history just so you understand where we're coming from. This is a letter that the Commissioner of Health of New York State sent out to all the hospitals in March 14th, 2012. Before, whether you guys know this or not, and that seems like ancient history, probably to most of you guys because we're already in 2018, at this point, there were no certified level 1 trauma centers in New York State. So New York State had trauma centers. Ron can speak a little bit about the history of trauma in the city. I'm going to turn it over to him. But at this point, the Department of Health had kind of given up on their ability to manage, certify, or figure out who should be a trauma center or shouldn't be a trauma center, and turned to the organization that the rest of the country has been using for quite a long time, the American College of Surgeons, and basically said, we give up. We need somebody to come help us with this, with figuring out who really should be a trauma center. Ron, you want to talk a little bit about history?
So just so that everyone understands the process. So the process, I don't do well like this because I have a big mouth just to start. But the process of becoming a trauma center, at least prior to 2012, was that New York State designated. They verified and they designated trauma centers. And basically New York State had its own set of standards. And the trauma centers had to meet up to those standards, and the state sent people around. So it was kind of the old boys club where people from upstate would come downstate, they'd look at your trauma center, and we came up with our own set of guidelines. And every few years we tweaked the guidelines, but the guidelines kept getting tweaked such that, well, you can't make that a guideline, because if you make that a guideline, then 3 trauma centers will fail their designation. So the guidelines kept getting dumber and dumber and dumber because it was harder and harder and harder to be a trauma center. So, and the state funded all of this, and we had to do a lot of work to go around and see different trauma centers. Finally, the state said, listen, we're not doing this anymore. We're going to do what just about every other state in the country does. New York and Pennsylvania were one of the few, and I think South Carolina maybe also. The state does all the work. But New York State said, we're tired of doing all the work. We want the American College of Surgeons Committee on Trauma to send in their own people to use their standards by which trauma centers get verified. And you could be a trauma center where the college says you meet all of the qualifications to be verified, and then New York State has to go and designate you. So it's possible that you can be verified, but New York State says we have enough trauma centers, so we're not going to designate you as a trauma center, even though you meet the standards necessary to be one. But that doesn't happen in New York City, right? Because New York City has 19 trauma centers, too many as it is. So this was radical, and this created a huge amounts of angst throughout New York State, because there were a lot of trauma centers that felt as though they would not be able to meet the standards necessary to become verified. And lo and behold, multiple years later, just about everybody has. But it's been great because it's really forced New York State to up its game.
Right, and so, the challenge for us in 2012 when this letter came out, we had been talking about pursuing trauma center status for quite a while in the organization, and it's the biggest hospital in Brooklyn, and it's the children's hospital for the city of Brooklyn. And given the fact that it was kind of clear early on that nobody else was going to be able to put resources into putting together a pediatric trauma center because nobody else had a children's hospital and had those things in place. We sort of managed to come to the realization organizationally that we had to make a trauma center work at Maimonides. And for us, that means taking a department like this, where more than half the patients are usually in the hallway. I'm sure this constitutes a really busy day. And then taking the patients from this, or like the minivan accident I saw yesterday with 6 unrestrained children in the back seat in Borough Park, throwing it onto this was a bit of a daunting task, figuring out how we were going to make all of this stuff work at the same time. So I want to just, before I go into how we did this and what we think are the useful things are, and really how you should think about this, I want a bit of a show of hands from people. And I'm going to ask you a question related to these 2 pictures. Now, this obviously is an image of trench warfare from World War I, where people are on the ground with their guns trying to defend themselves against the enemy invading their basement emergency department. And this is a stock photo of a bunch of very, very happy people who are shiny and totally artificial. So just for reference, those of you who feel like in your training environment, your relationship, and I recognize that every individual case is different, right? So you probably have moments of trench warfare punctuated by moments of shiny, happy stock photos, right? But in your department and where you currently work, do you feel like your relationship with your surgical colleagues is more like A, trench warfare, or B, shiny, happy people? So how many people feel like their relationship with the outside departments has a trench warfare component to it? All right. So
that's almost
half.
40–50%.
All right, and how many of you feel like, every time you're involved with the consultants, it's shiny, happy people, let's smile and get together?
And if you're Maimonides, you better be raising your hand.
So it looks like we've got about 40% of the people in trench warfare and about 5% of the people with shiny, happy faces. So that's a pretty good survey response rate, I think, actually. So, for us, we were this in 2012, right? Without a doubt, there was a lot of trench warfare, sniping, backbiting. I can't believe the ER screwed that up again. I can't believe the surgeon screwed that up again. I don't want to talk to them. I don't want to talk to them. Blah 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 blah. Right? But we've managed not to get completely to shiny happy peopleness, but we've come a long way through a lot of different things we're going to talk about here. But importantly, we did this with a plan to get there we managed to get this together by 2016, and we're going to talk a little bit about this, but in 2016 we finally got our letter for August that said you can go ahead and start your trauma. We got the approval to begin trauma center status designation in August of 2016, and that's when we turned on to adult and children both. So the things I'm going to talk about, we're going to kind of go through some of this stuff quickly and go back to a little more audience participation. It's communication, education, simulation. I hate reading slides, so I'm not going to read this. You can see what's up there. And we're going to kind of talk about how we got there. And I'm going to feel free to chime in anytime, Ron, as we go through some of this stuff. But this is frequently what surgical and emergency medicine consultative processes look like, or looked like at the time. And I think the important thing to remember is that all of this stuff does come down to communication. In the 2 most important components of communication, and this is the soft, fluffy stuff that we're going to mostly avoid, but I think is worth talking about, is communication happens better when people are familiar with each other and people have a shared set of goals, right? Ideally, you have a shared culture, right? And I think emergency medicine people tend to speak pretty easily with emergency medicine people because we share an entire culture together. But surgeons in emergency medicine don't necessarily share a culture, and so to get closer to that, having at least familiarity with each other, things like rotations, combined conference, simulation, there's a whole presentation on trauma simulation in a little bit from Colleen, as well as a set of shared goals are important. So getting people together, in some sense was the first step. Getting people together to have a relationship with each other, a real relationship that doesn't involve just yelling at each other, and having a set of shared goals and a shared outcomes that you're responsible for. Ron and I share responsibility for the outcome of trauma patients in the organization. So social events. I want to make a comment about drinking, but there are a lot of ways you can get people together. We get people together via educational content, via simulation. We actually started this process really by getting the surgical attendings and emergency medicine attendings to go out together for a cocktail hour, which we're doing again next month. And getting the surgery residents to drink together. It's not about the drinking, right? Because I'm sure this person's drinking Coca-Cola out of that little ball glass. But it's really about having a relationship that isn't just in the emergency department when you're face-to-face fighting each other.
I just want to add, I think that's one of the big things that we started out doing was familiarity is key. And if every time we would go down to the emergency department, we were faced with a room filled with strangers, then that automatically puts somebody on guard. And so what John and I sat down and said is, okay, so how can we create truly that one happy family? So how can we integrate the programs so that I knew the ED attendings, the residents knew the residents, and it was familiar. My view of going down to the emergency department is walking into the ED, seeing the ED attending, and being able to go over, pound on back, saying, hey, how's your day, what's going on, how are the kids, and having lunch with them and stuff like that, so that there becomes a personal relationship, not only between the ED attendings, but between the attendings and the ED residents, who are very responsible for running the shows down there and creating a good sense of camaraderie. And that's when, you very generously agreed that I said the emergency department residents should rotate onto the trauma service and take care of the patients on the inpatient side. So you have a feeling for what happens when the patients leave the basement and come up to the floor. And that's turned out great. We have one resident on the trauma service every month, and we have one EM resident rotating in the surgical ICU every month. And that just makes it very familiar, and as soon as people become familiar, it automatically reduces the volume down in the ED.
Right. And so, there's a lot of stuff about communication, and you can see this one says that, CTs get done quicker. You can find a ton of papers about improving communication and how improved communication improves clinical care and improves outcomes. I'm not going to go through all of these specifically, but they essentially all come down to the same thing, which is that the better you communicate, the fewer errors you have in the department, the faster the patients get care. And I think this just kind of is self-evident, right? But we're not great at communicating with each other because we don't necessarily share a culture. And I want to get back to the end of this at the end and talk about why this is important for you and what I want you guys to take away from this to your jobs in the future. This was my favorite study, by the way, looking at this, that said that actually trauma room management was better when they blindfolded the trauma leader. So we're thinking about doing a double-blinded study on this because the trauma leader actually had to actually ask people what was, had to hear, there was closed-loop communication. There was feeding back, there was communication back and forth. So we're planning a double-blinded study with blindfolding EM attendings and surgery attendings for trauma management coming forward in the future. So any other studies centers want to participate, let me know. So Ron talked about a little bit about joint education, getting residents from both services together to talk, both in conferences, shared M&Ms, presenting jointly. We also recognized well before, it was 2 years before we went live with this, that if we don't have the surgery residents, EM residents, and importantly EM nurses together in the simulation center on a regular basis, that we were not going to get there. So every Tuesday we've been doing joint trauma simulations with our nursing staff, our surgery residents, and our EM residents, led by EM and surgery attendings both, to get everyone on the same page. And then we punctuated that right before we started in situ simulations. How many of you guys are doing simulations in your resuscitation areas or in parts of your department while the shift is going on with the people who are on shift? All right, how many of you guys love stopping caring for patients and taking care of a mannequin on shift? Right? It's Sally, of course. It's not the easiest thing, but the reality is that this really works. We did 16 to 17 of these in the 8-week run-up prior to starting to getting our trauma center accreditation, to beginning to take trauma patients through the ambulance system. We found 208 latent safety threats that we were able to correct and sort of extinguish over the piece of months. And this had to do with people not knowing how to get blood, people not being able to communicate well, not knowing who the team leaders are. And I will tell you, the first few of these we did were pretty
Scary.
chaotic.
Scary.
But by the end of the 2 months, and we did this at 10 in the morning, we did it at 3 in the afternoon, we did it at 5 or 6 at night when the room was hopping, we did it at 5 in the morning. We just made a commitment to do it, and yes, the staff was pissed off and annoyed, but everyone got it. It was 30 minutes. Nobody died. Fortunately, we canceled it once when the room was really exploding. But it makes a difference to do it live in the room, and by the end, it gets a lot better. And it's worth practicing what you do in the place you're going to do it real time. There's a couple little studies out here. One that showed that teamwork gets improved. This one actually demonstrated this one talked about identifying communication errors and difficulties. This one talked about decreasing time to operation from 2.5 hours to basically 1 hour, a little less than 1 hour. By practicing simulation, they were able to reduce the time to the operating room in real patients after simulation in the emergency department. So getting people together to practice makes a big difference.
So I just want to say thing, you mentioned trauma M&M, and I think the big fear that people have when you do a case presentation, because what case do you always present? You present the disaster patient. And so it's always, the emergency department is always nervous that when one of their residents goes up to present the case, that all of the surgeons in the room will throw apples and tomatoes and whatnot, and it will become a very malignant, non-educational atmosphere. And again, we recognized this when we started putting this together, and I said, it's not a trauma M&M. It's a trauma conference, a combined ED trauma conference, where we take a case, we present the case, but we present it in a very academic way where emergency medicine says this is how things went. Then my surgical residents will present a little bit about what particular management issues, whether or not it be the surgical AOA, or how to manage a pelvic fracture or something like that. But it's always educational. It's never, well, why did you do that? It's always, this is the data, this is what we did, this is maybe what we could have done better, and next time let's look at or think about doing it this way. So again, everyone is okay sitting in the room, nobody gets nervous, and it's really educational, and the next time that that patient rolls in the door, everybody should be more familiar with how to manage whatever situation we decide to base the M&M on.
Right. So in terms of planning, the stuff where there's a little bit of controversy, and I'm just going to ask you guys a couple of questions, but as we go here, it has to do with how you run the room and how you share what you do. And I will tell you, the literature is replete with utterly useless studies that tell you little to nothing about how you really should do this. So trauma room management, for example, is one of those things where the ACS process mandates that a surgeon is the leader of the trauma resuscitation, right? There have been a couple of studies looking at whether you need a surgeon or don't need a surgeon, recognizing that there's a lot more non-operative trauma now than there was 20 years ago. So one meta-analysis I can find that actually looked at some of the literature that basically showed that they didn't really think there was a particular difference. There was no significant difference in outcomes, whether it was a surgeon or non-surgeon, team leader. Although they did note that there were slightly fewer injuries missed when the trauma team was run by a surgeon. So just out of curiosity for those of you guys who, when you're working in trauma centers, how many of you guys have a surgeon running the trauma resuscitation? Show of hands. And how many of you guys have an emergency physician running the resuscitation? And the other 90% of you or 80% of you never see trauma patients? Okay.
Or does it depend?
Or does it, I guess I should say that. For how many people does it alternate days? Because there are a couple other systems. So some of you guys use alternate days. Does anybody else divide it up differently? Level 1s or level 2, some people divide it that way. Anybody else divide it up in a novel way that we haven't heard of? So, this is our chart, and I'm sure most of you guys have a chart like this on your wall of who does what. You've got EM1s and 2s up there, EM2s and 3s at the top. You've got your surgery attending, your surgery junior resident. And I'll note the box at the bottom, which is the trauma team leader, which says ED, and trauma attending. And I'll note that in our trauma room, if you take a look at the box at the bottom, Ron made this observation to me the other day, and it's really true. The box at the bottom is a double wide box for us to jointly manage these patients, right? As much as one person in the end needs to be, there needs to be a joint decision at the end. We all need to be on the same page. right? It doesn't have to be an authoritative or an authoritarian type approach to this. It really can be a combined approach for the EM attending, the surgery attending, or standing shoulder to shoulder, not soldier to soldier, although it feels like that sometimes, shoulder to shoulder, making decisions jointly and collaboratively. And if you want to say
and this was that wasn't an accident. That wasn't somebody went over the line when they were painting. Again, I felt very, very strongly about this. That if you go back to the one, can you go back one? So the small boxes are where the residents and the nurses stand, and those are very clearly defined. But if you put a small box at the top, then my fantasy was that the surgeon would walk in, because the ED attending was there, the surgeon would walk in and kind of hip check the ED attending out, and that would automatically create a sense of conflict. And it's the surgery people on the screen right, and the EM people and nursing on the left side, and that if there was conflict up top, there would be conflict on the sides. So I said, well, this is easy, because it is joint. It's number one, it's nice to be able to chit-chat while you're doing the trauma resuscitation with the ED attending. But it's also very easy when you're standing side by side to go, listen, what do you think? Or this guy's pretty screwed up, or whatnot. So it just made sense to create this environment, both pictorially and publicly, that we just get along and everybody should just get along. And it just makes it much easier to run the resuscitation. You're going to talk about the level one.
You want to say something about that now? Yeah.
Okay, so I am a big proponent of resident education, and as trauma director, I believe that my responsibility is not only training my surgical residents, but training emergency room residents. So I tell this to my residents all the time. When you leave the big city academic medical centers and you go out to the rest of the country, it's kind of like where some of those people are saying, come here to Florida and blah, blah, blah. Emergency medicine is alone in the ED and the surgeons are out playing golf. And that's just the reality of the situation. And I recognize that you guys really have to understand the initial resuscitation of a trauma patient. And I tell that to my residents. I say, you can't box out emergency medicine, because they're the ones that are going to be taking care of the patients in the majority of the country for the first half an hour or so of most trauma resuscitations that are not in big trauma centers. So I recognize that emergency medicine had to feel part of the resuscitation, and they need to feel comfortable leading a resuscitation. So what we agreed upon is that the level 2s would be run by emergency medicine, and we would be there, and supportive, helpful, and kind of listening along, and again working conjointly. And the level 1s, since the level 1s are the patients where you really have a few minutes to make a decision about, are we going to the operating room, or where are we going, what should be going on, who should be called, when those decisions are really time critical and are really revolving around surgical maneuvers, those should be run by the surgical attending. And that's just worked out very nicely.
Yeah, I think actually in practice most of the time, we're so used to managing these patients that we're both at the end of the bed and things just happen, and there's so much stuff going on below the ones anyway that
I agree, but on paper, that's the way we divvy things up. But again, conjointly, the 2 people in the box and the 2 people at the top of the bed are working together to make sure that the patient moves forward.
So just on the procedure, I just want to do a show of hands. How many people are totally satisfied that they get all the procedures they want out of a trauma resuscitation? One person in the back, awesome. How about on the airway side? How many of you guys have anesthesia routinely managing airways in the emergency department for the trauma patient? A few folks. And how many people is it always emergency medicine? All right, most of the room, that's great. And just while we're on the subject of procedures, how about chest tubes? Surgery does most of the chest tubes? Hands? EM does most of the chest tubes? A little less certainty there, just out of curiosity. How about the ultrasounds? EM? Yeah, both strong. The surgeons ever do the ultrasounds?
With the right truck?
So I'm going to make a little plug here along the lines of what Ron's saying. And Ron's been great about this, and I'll let him say something about the airways and the chest tubes too. But having a system, where I think Ron's point is exactly that. The point to that your surgical colleagues should be that way, and I'll let Ron take the surgical perspective. But I will tell you from an ultrasound perspective, for example, most of us have infinitely more familiarity and comfort with ultrasonography. And I will tell you that ultrasound to the bedside is a great time to teach the surgery residents something that they don't get to do regularly. Our residents spend 7 weeks on ultrasound over the course of their training. I'm not sure how much the surgical residents spend, but I think they basically get all of their education in the trauma room with us. Ron, you want to say something about the, yeah, you want to say anything about your feeling about emergency medicine, the chest tubes and the airways?
Well, I think, again, I think EM should be doing all the areas. I have no problem with that. What I do think is that anesthesia should be part of the process, because what you don't want to do is you don't want to have a threatened airway where you try twice and you can't get it, and now you're calling anesthesia who's coming from 7 floors away while your patient's turning blue. So I think having them there and having an understanding that they will stand back and let emergency medicine do their thing, I think that's important. And I think the same thing is true with chest tubes. That again, when you guys are alone in the emergency department, you need to be able to put in a chest tube. And I tell my resident, there is no such thing as a PGY5 surgical resident that can't put in a chest tube. So just take a breath, and we allow our surgical chiefs to take the EM resident through it. I was going to say that the way we solve this problem is every patient gets 2 chest tubes. One put in by emergency medicine, one put in by surgery. That solves the problem.
That's a better way to divide it up even. You know, we can talk about surgical. I want to get to a couple of things. We're sort of short on time. I mean, the crikes are crikes. Just out of curiosity, how many people are doing Roboa in their emergency department right now? A few. And EM people putting it in, or surgery? Just surgery. Yeah, right. When the surgeons are going to be the ones taking care of it at the end. We'll see how that goes. Plays out in New York. So I want to make just a couple more plugs about how you get this. Once you've got the culture there, how you continue to get it there, and then we're going to close. Really quick, I've gotten my 5-minute signal. So we have video cameras rolling in our recess rooms 24/7, 365 with 6 months worth of backup to go back and look at everything. There's no better way to keep everybody honest than to have video and audio, high fidelity video and audio of every resuscitation that happens, and playing those videos in conference periodically or in joint sessions is extremely helpful. Just out of curiosity, how many of you guys have video in your recess rooms? How many of you have it rolling 24/7? A couple, great. And if those of you guys who want it, you know, find me afterwards, because our lawyers are feel very strongly that they should be video recording absolutely everything that happens in the ER all the time, and that we're all much better off if everything's on video. But that's a topic for a different conversation. And one other thing just around continuing this is we've taken the debriefing and stuff that we've learned from simulation, and as part of a broader simulation effort on the part of Mount Sinai, Montefiore, and Maimonides, we've gotten really aggressive with clinical event debriefing, identifying problems jointly by getting surgeons and emergency medicine people together with nursing to identify problems afterwards, recording those problems and fixing those problems. And we've actually managed to continue to fix a lot of those issues by pushing communication as we go. So just to conclude this a little bit, you know, getting to a place like this where you're together and you're working jointly and you're not like this is the kind of thing that takes continuous work, right? And the reason I want to make a plug for why this is important to you as residents, and when you take it to your job, you know, what you can take to your job when you go out there, right? There are still a lot of departments in the world where emergency medicine has that bunker mentality and sits in the basement and it's us against the rest of the world, right? But it doesn't have to be that way, right? And it's not to say that everybody wants to live their lives as a shiny stock photo actor, you know, but the reality is, right, that you can spend your career doing this, or you can spend your career doing this, right? And in reality, it's your choice. Right? You do have a choice. You have a chance. You can control the culture. You can change the way people talk to each other. You can change the way people look at each other in the department. And you can spend a little time not just feeling empathy towards your patients, which you know we all talk about in terms of the wellness world, and empathy for your colleagues, but empathy for the surgical staff and the anesthesia staff and everybody across the way. Because the reality is, the happier people are in the department, and not just your people and not just the patients, but the happier your surgical colleagues are, and your medicine colleagues are, and your critical care colleagues are, the more power you have in the organization, right? This is how you get power in the organization, right? You can spend as much time fighting for what you think you need in the emergency department against everybody else, and you're not going to get everywhere, right? But When you start to get real power in an organization is when it's not just you fighting for what you need in the emergency department, but the colleagues who share your values, share your culture, and share your patient outcomes, share your same needs. That's when you get real power in an organization. And coming into a department and saying, you know what, I'm not going to tolerate the trench mentality. I'm going to focus on the patients. I'm going to focus on how we can work together. I'm going to focus on how we can be sort of shiny, happy people together. That's where emergency medicine's real power is, because we really are the engine of the hospital. Almost every admission in almost every hospital in New York City comes through an emergency department. We touch every single patient that happens, and if the emergency department's not working well, the hospital's not working well. And if the ED's not working well because of cultural problems or because of communication problems or because you're too busy fighting with everybody around who's going to do the airway that day or who's going to do the airway this day, and the surgical colleagues want to hit and check the folks out of the way and do the chest tubes, you know, all of this stuff actually just hurts you, right? It hurts your ability to get what you need organizationally. It hurts your ability to drive change in the organization. It hurts your ability to get the money you need to care for your patients the way you want to care for your patients or the things you need for education. And the more time you guys spend in that shiny, happy people world with your colleagues, the better off you're going to be, the better off your patients will be, the better this stuff will work in your resuscitation base, and the more likely your patients are to live to 100 and continue smoking their way through life. So that's the end of our talk. We're, I think, at time or just slightly over, but thank you guys very much.